That's strong enough.
From Edinburgh.
Okay, I think we're live now on YouTube.
You think you've sorted it out?
Yeah.
I should have a look if I go onto YouTube. Follow the link. I can see a baby cooking.
You're all right.
So you think you're ready to go there?
Yeah, I think so. That's what it's saying on YouTube at the moment. It's not streaming.
So it's the link. So just go on the. This was the link itself. You can't seem to get it.
Oh, I see.
You go on.
Yeah,
The problem is most people are going to follow the link, aren't they?
Should I cancel?
Oh, no, it's not.
We've got a good thing on the job there, Oh, it's meant, guys.
Delphine, are you ready to go?
Yep.
Okay. Right, we'll make a start then, everyone. Apologies for the usual delay despite our best efforts. Good to have you all here for the GASOC Journal Club that we're hosting here at the Royal College of Physicians and Surgeons in Glasgow with colleagues from King's, Oxford and Sarah's house.
Hiya.
And Ewan's house as well, I think. The focus of our discussions today is going to be a couple of papers that have been recently published by the Global Search Collaborative, of which I imagine a few of you have been part of. I've been part of that collaborative, as has Ewan, who hopefully will join us shortly if he's not completely connected. You should have hopefully received details of the two papers we're discussing, and we're going to provide outlines of them just as a springboard for discussion. As always, robust debate is encouraged. It's a strong academic atmosphere, despite the fact that we're authors of these papers. We want to know exactly what you think, negative and positive, and hopefully have a good discussion on what the implications of these papers are. I think it would be nice, as always, to introduce ourselves. So maybe begin here in Glasgow. We'll go quickly around the room, and I have to apologise, we don't have our normal microphone. So let us know if you're not hearing us, and I will relay what people are saying in the room. So do you want to introduce yourselves, just your name and what stage you're at? I should just finish and start working on some more in Glasgow.
Joanna, medical student.
James, and I'm Stuart Ferguson. I'm a surgical registrar in the West of Scotland. Can I just check, how well did you hear all those voices?
Not brilliant.
Not very well.
Okay, well, we will try and amplify. And can you hear me okay?
Yes.
Yes.
Yeah, okay, great. Kat, are you happy to introduce the two of you?
Yeah. So I'm Professor Kokila Lako, pediatric surgeon in Oxford.
And I'm Captain of Peds Surgery Reg in Oxford.
Sarah?
Hi, I'm Sarah Davidson, anaesthetics reg, currently on mat leave, with 30 masters, who is 9 months. Who hopefully will be quiet and not interrupt.
Okay, and Kings, introduce yourselves.
I'm John, I'm a surgical registrar, just starting a PhD here as well.
I'm Soji Ademewa from Lagos, but here as Commonwealth Fellow at King's.
Naomi, Pete Surgery Reg, and I'm doing a PhD in global health.
Hi, I'm Anu Paul. I'm a paediatric urologist at Great Ormond Street Hospital.
I'm Delphine, one of the medical students at King's.
I'm Natalia, just started PhD with King's to work on the health system strengthening in Sierra Leone.
And I'm Becky, I'm an anaesthetic reg in London.
Did you hear any of that?
You're all very welcome. Thank you very much for joining us. I will make a start then on our first paper.
So sorry, before we start, could I ask if Kings could go on microphone mute? Could we just getting like an echo from you speaking?
Okay.
Sorry, thank you.
Yes, thanks. That's a good point. If you're not speaking, it would be helpful if you have your microphone on mute, and don't forget to unmute it if you want to hear your views.
Down at the bottom there, that one. Yeah.
I'll leave it and then when we
Okay,
start.
can you see my screen okay?
Yes.
Yeah.
Yeah, it's good.
Good. So 1 second, just as this loads up here. Okay, are you seeing that all right? You'll have to unmute your mic.
Yes.
Thanks. Right, we'll make a start then. So our first paper is surgical site infection after gastrointestinal surgery in high, middle and low income countries, published in the Lancet earlier on this year. Most of us are familiar with the Global Surge Collaborative. It's a network of now over 5,000 clinicians, both medical students and qualified doctors in over 100 countries. And it was formed almost 4 years ago now in the UK, but with a strong emphasis on inclusivity and collaboration, with the collaborative viewpoint of full credit sharing for activity undertaken. So all of the Global Search papers are published as Global Search Collaborative as author, with individual lines for exactly what everyone has done. So our author lists extend to many ages. So why surgical site infection then? Surgical site infection is the most common post-operative complication, and it is associated with many other adverse outcomes. Not to say, of course, as well, that it's painful and unpleasant for the patient and expensive to deal with. The World Health Organization produced global guidelines very recently for the prevention of SSI, and in terms of the evidence out there for how we can tackle this problem, it's particularly difficult to make judgments in low income settings, because we're usually deriving conclusions from high income country settings. We really don't have much of a handle on antimicrobial resistance in SSI and how much this may be a problem as well. So Global Surge 2 had a published protocol which set out to determine the incidence of SSI following both elective and emergency gastrointestinal surgery in all human developmental index types, that's HDI, countries. And then secondarily, we were interested to describe the epidemiology of the organisms causing SSI, the instance of antibiotic resistance, the tests that were being used to identify them, and the impact of 30-day follow-up. That's the link there to our published protocol. So who participated? It was a multi-center prospective cohort study. If you were a center undertaking gastrointestinal surgery, you could take part no matter what part of the world you were from, no matter how few cases you were doing. And all of those cases were derived from a 2-week period of data collection. If you did one case that met criteria within that 2-week period, then your centre could be included. But obviously the busier centres were including over 100 cases. There was no age restriction and we excluded cases which were undertaken for primarily a vascular indication or gynecological, obstetric, urological, or transplantation. The data that was collected was designed to be pragmatic. We could have asked a great deal more detail, but we wanted this to be deliverable in many different kinds of income settings. So we collected some basic demographics, comorbidity data using ASA, details in surgical pathology and procedure, antibiotics used, and if an SSI did occur, the details if they were obtained of culture and resistance to the antibiotic given as prophylaxis. We used the REDCap system for centres to securely upload their own data following local ethical clearance. One of the significant criticisms of the first global surge study of emergency laparotomy was that people argued that you had no idea if the data meant anything or not. There was no form of validation. So we took different approaches to try and address this problem as best as possible in a pragmatic fashion. So first of all, we self-reported the approach to certain key processes in data collection. Secondly, and perhaps more substantively, data validators were separately recruited. So they were different to the primary data collection team. And we wanted to know how well they were picking up on cases. And we chose 6 different data points rather than all of them to assess accuracy on all of those. That, of course, has its own problems. Secondary appraisal of data is not necessarily better than primary, and these validators may have had less information available. And then thirdly, there were some team interviews undertaken to qualitatively assess collaborative engagement. And this is the result. There were over 12,000 patient records suitable for analysis after records were removed for low completeness, which, as I say, was not formally defined in the paper. Over 300 centres, 66 countries, the majority of which were from high developmental index countries, a third from middle and 10% from low income countries. Interestingly, a third of the cohort were suffering from gallstone disease of various descriptions, and about another third from appendicitis. 80% of the operations were clean contaminated. So some further results. Here is a graph that demonstrates how, as human developmental rank index increases, along the x-axis there, your probability of surgical site infection increases. I've chosen to express some of the other results using a graph that visually depicts the odds ratios of different variables being associated with the presence of an SSI. So using the high income countries as index, there was no significant increase in SSI in middle income countries, but there was a significant increase in low income countries. Taking ASA1 as baseline, unsurprisingly, ASA2 and 3 or more were associated with an increase in risk of SSI. Diabetes was significantly associated with an increase. Interestingly, being a non-immunosuppressive medication was not. If you had a surgical safety checklist available and it was not used, that very significantly increased your risk of SSI. A laparoscopic approach very significantly decreased your rate of SSI to about a third of that of open surgery. The use of antibiotics was not quite associated with a reduction in SSI, and clearly contaminated and dirty operations carries an increased risk. So a little bit of data about when antibiotics were used. So antibiotics. So this is basically patients who did have an SSI. How many of them were an antibiotic not used? So that's this line here. 9% of patients in high developmental index countries weren't getting an antibiotic. Sensitivity to the antibiotic was present in about a third of cases. Resistance to antibiotics was significantly higher in low income countries compared to high, and sensitivity wasn't always available. So to summarize the results then, the majority of this cohort came from high income countries, a third from middle, and 10% from low income. Wound infection was significantly higher in low income countries, and drug resistance was apparently more common in low income countries. The paper made quite a splash on social media with an enormous altmetric attention score. I think this is one of the advantages of a collaborative approach with lots of social media active collaborators. So my own thoughts before you offer yours on the strengths of this piece of research. It's certainly a very important area for research. It's an enormous team collecting data from many diverse settings. It was using a standardized protocol where outcomes were clearly defined, and we used a standard definition of SSI. Training was mandatory for data collectors, that was online. And I mentioned earlier data verification. So those who were tasked to go through other alternate sources of information and try and ascertain how many cases were correctly picked up, the result of that analysis was that 93% of cases were correctly being picked up. And we took certain key pieces of information to see whether they were being accurately recorded, and accuracy appeared very high for age, for example, and for the categorical variables was generally very good, but less good for one of the categorical outcomes. Limitations, as I see it, are that this is a convenience sample. It was whoever wished to take part, and we can't claim to have a representative section of each of these different category types of income countries. Follow-up was quite variable. Our outcomes were supposed to be at 30 days, but pragmatically, quite a lot of the time, outcomes were being assessed at the point of discharge rather than necessarily at 30 days. Many patients who had an SSI did not have a wound culture, and there was lots of information because of our pragmatic choices that was missing, such as antibiotic choice. One of the findings that the media found most interesting about our paper was this finding of a high percentage of wound infections that were apparently resistant to the antibiotics that were used. But this is a very problematic finding to understand, because there was no standardization at all of how we defined antibiotic resistance. We certainly have no clarity about the quality of laboratory approaches that we're taking. Right, let me just put you back on full screen. Okay, are we all seeing each other now?
Can we have the light on the call?
I think you maybe need to unmute your mics if you want to talk. Can you see me okay?
Yeah, we're still sharing your screen.
Okay, are you seeing the Skype screen now, or are you seeing my PowerPoint?
We're seeing the Skype screen, but on your screen.
Okay, that's fine. As long as it's viewable, that should be okay. Ewan, are you on the call now?
Stuart, how did you define surgical site infection? Was it just inflamed wound, or was it pure pus or?
So we used the CDC standard definition. And I don't have it written out, but it was the standard CDC definition.
Do you have it in front of you?
I see it in front of me. But it certainly was there in our published protocol, and it was there in our training module that all data collectors had to undertake. I think it was along the lines of pain and discomfort and erythema. It's one of these ones where there were major and minor criteria that people had to make. Right. Okay. So we've got someone who's found it.
Yeah, we found it.
Yeah, we've got it.
It's
It's very long, and as you say, it's it can be superficial, it can be deep, it can be within the organ or the space, and there's various subdivisions within those three criteria. But it's all within 30 days of the operation.
Right. Yes.
The reason I'm asking is that the concept of erythema is different in Caucasian skin to black skin. You won't pick it up. You just see pus coming out. This is from experience. So maybe your reporting from the low-income countries was mainly just when they saw pus coming out. Or
so the criteria is at least one of the following: 1, purulent discharge; 2, pain or tenderness or localized swelling or redness or heat or fever. So there certainly were a number of other features that would not be limited to Caucasian skin. Thanks for the question. Any other points of clarification that people want to make?
I've got another one from Oxford, if we're on the hot seat.
Great.
For the finding of significantly increased infection if you had no WHO checklist and it wasn't, or didn't use it and it wasn't available, compared to didn't have it and it wasn't available. How did you explain that as a group?
Well, we haven't made a suggestion in the paper as to why that was. I suppose there is a potential that it could be associated with other variables, such as the degree of urgency of the operation. I'm not sure if we explored whether checklists were used less often in emergency procedures, for example. That could be one plausible explanation, or it could represent an institutional attitude, perhaps, that meant that other processes that should be followed were not being followed, such as skin preparation beforehand. Any other thoughts yourself?
I'm just interested because I can't see why the fact of it not being available versus being available but not using it would make a difference. I just think that's very interesting. I'm not sure. Maybe if you've got it but you're not using it, you're aware of what it involves, i.e., like you say, skin prep and considering antibiotics. So maybe it's the knowledge of what it involves. Having it is important.
Yeah.
were all the countries or collaborators using the surgical checklist? Because there are centers that don't use them.
Yeah, so I seem to remember that it was around about 90% of the high-income countries were using the checklist, whereas the figure was around about 30% in low-income countries.
46. Yeah.
I don't know if Ewan is on the line. Are you there, Ewan? No, not hearing from him. Never mind. He may join later.
your drug resistance that you found mainly in the low-income countries,
Yes.
did you identify the drug?
No. So that is certainly one of the limitations of our data, is that we did not record the antibiotic that was used. That's a significant limitation. And that was a difficult call, but we felt that it would be difficult to reliably collect all of the data points that would be relevant and then make sense of them in a subsequent analysis. Any other questions from Oxford then?
Just Oxford. We'll give up the chance, but one last question. So what is the punchline message from this paper?
Well, I think the punchline is that surgical site infection is confirmed to be a very major problem. Interestingly, in our data, surgical site infection is strongly correlated with mortality. And it, on the basis of our information, I think it is reasonable to conclude that surgical site infections are more common in low-income country settings. We need to pay attention to addressing this issue if we're going to improve other surgical outcomes in general. The conclusion that you might draw about antibiotic resistance is quite concerning. Apparently, taking into account all the methodological weaknesses, antibiotic resistance is really very common in low-income country settings. A third of the organisms were resistant to the antibiotic used, and this might reflect poorer antibiotic stewardship. Is certainly one of the things that's commonly argued. Can I ask Kings for their views or their questions?
I've got a question, if that's all right, Stuart.
Great.
I was just thinking about resource use compared in the different settings, whether in low-income countries or low-resource settings, it's more likely to only do a swab to test for sensitivity and resistance in those patients that look like they're not responding to antibiotics. And therefore, out of the patients that are swabbed, you're likely to get a higher proportion that are resistant, whereas in high-income countries, you're more likely to just swab lots of patients that might potentially look a little bit red and pussy or a bit oozy, and therefore the proportion of antibiotic resistance is much less in high-income countries because you swabbed a greater proportion of the patient.
Okay, it's certainly an interesting hypothesis. I'm trying to find the table that shows how many wound swabs were.
It shows actually that, yeah. Sorry.
It seems to remember it didn't actually vary all that much between different income environments.
Yeah,
it's in one of the, it's in table number 3. Sensitivity is not available in 43% in high income and not available in 32% in low income. So it looks like they didn't swab as much, perhaps. No, the table 3 is an analysis of organisms from an SSI that did have a wind swab.
Oh, I beg your pardon. Right.
Yeah. So I have a feeling it wasn't enormously different, the number of wind swabs that were taken between the different environments. Sorry, it's just a bit hard posting and trying to read the paper here. Sorry.
I'm just looking at here. So okay. So it looks like in table 3, at the top, N equals is the number of patients that had a swab. And then in the actual table body is how many were actually resistant to an antibiotic.
Okay.
So actually...
sorry, on you go, Naomi.
Yeah, you're right. That there's not really a higher proportion that have been swabbed in high income countries.
Yeah, which is itself quite interesting, isn't it?
I'm just quite surprised that so many patients had a swab and sensitivity tested in the lower resource setting. Can I ask Soji, I mean, you come from a highly developed centre a developed centre, a tertiary centre rather than a district hospital centre. But
Yes.
What's your opinion of how often patients are swabbed and sensitivity tested for and such like?
Right. Usually, it's not every time that we test for sensitivity. However, if you have been managing a patient and is not responding to treatment, then you want to know why, and in those cases, then you'll test. But one thing that I need to bring to your attention is that we have, out of the 12,000, only about 600 that were analyzed for antimicrobial resistance. And of that, it's pretty obvious that the proportion from low-income country was much higher in terms of resistance. And I don't know if it's in this data, but I think somewhere we also found out that almost 96% of patients undergoing surgery in low income countries actually have antibiotics prescribed, unlike in high income countries when it follows a proper guideline. So I think the importance of this paper, like Kokila was asking, is also to bring to the fore the need for guidelines in the use of antimicrobials in surgery.
I wonder whether the case mix could have affected the proportion with resistance to antibiotics, because there's a lot of patients with.
Well, I'm not too sure from the case mix. It was too different. I don't think so.
Well, there's lots of cholecystectomies in the high-income countries. Laparoscopic cholecystectomies that might happen
and appendectomies as well. Again, that's one of the quite interesting things.
Yeah.
This is all the appendices. All the other pages.
Jude, one more question. What proportion of the group were under 16 or under 12?
I can't tell you that in terms of proportion, Kakila.
I can answer that. It's roughly about 40-45%, but that data has not been analyzed yet.
Thank you.
Any other questions from Kings? Any other?
My other question is to do with laparoscopy, so I'll save it for the laparoscopy paper.
Yeah, we'll major in laparoscopy for the next paper discussion. Okay, I'm conscious that I've slightly ignored our group here. So, any of our Glasgow audience want to ask a question or offer a criticism?
I'm not sure if you touched on, but when you mentioned the lack of wound culture in patients that did have a confirmed surgical site infection, do you know where that came from? That patients that had a surgical site infection weren't swabbed, that was high, middle, or low on the scale?
Okay, so did you hear that question?
Yeah.
Yeah.
No, I didn't hear the question.
No, we didn't hear the question, sorry.
Okay, so the question was, what proportion of wounds were being swabbed in high versus middle versus low income countries?
One of them, coach.
Was a high proportion of people surgical site infections having a wound swabbed down.
Yeah.
So it's all that coming from the high end countries.
So, unfortunately, I couldn't see that picture immediately, and my computer has just decided to reconfigure itself. So all of the supplementary tables are unavailable to me at the moment. Sorry about that. But I think it was similar between all the different income settings.
confirmed surgical site infection, why would you not swab them?
So there was a good question. Why would you not be getting a swab? I guess one of the reasons might be that not all wound infections will produce pus, because that's only one of the criteria. And if that were the case, then there's less material with which you can swab, and so people necessarily run a clot of blood over the top of a scar if it's red and swollen. Any other questions here? How much store do you think we should put on the feature that the media found interesting about antimicrobial resistance? What's your opinions?
I guess it's media hype, probably, because it's trendy and it is a concern for lots of people. But I'm not sure what annual papers shown that there is an alarming proportion of antimicrobial resistance. But I don't know what other information we can gather from it in terms of how, what do we do about it?
I think that hype is coming from the primary care level, because there's been criticisms to GPs that any child that just comes in gets an antibiotic for a sore throat. So I think the public has been made aware that a lot of antibiotic usage is happening in the high-income countries. And I think in your paper, the concept of antimicrobial resistance just got picked up as a word. And
yes.
Ran with it.
Okay. Ewan, have you joined us now?
Can you hear me?
Yay!
Yeah, sorry, I've been having Skype issues.
So you've maybe heard some of the conversation. We were just moving on to the feature of this paper that the media had been most interested in, which was the findings in antimicrobial resistance. And we were just discussing what we make of those.
Yeah, I haven't heard all the conversation, so I apologise. I mean, this comes on the back of broader understanding that antimicrobial resistance in low and middle income countries is increasing. And that's been seen across lots of different hospital and primary care specialty areas. As you probably touched upon, the amount of data within the Global Surge 2 study is relatively small, although that does show you that in order to get wound swabs on a proportion of patients, you need to be looking at 12 or 13,000 patients. But I think it was picked up because it really does speak to, I think, genuine concern that antimicrobial resistance is not only a problem of high income settings, but is becoming more so a problem in low and middle income countries.
One of the questions that's been asked a few times, and I couldn't find the data immediately to hand, was how the wound culture proportions varied between high, middle, and low income settings, as in what proportion of SSIs were being analysed for their microbial activity and resistance. I seem to remember it was relatively constant between each division.
Well, yeah, that's right. And in the UK, more broadly, not within this study, cultures of surgical site infections are only done in around 10% of cases, and sensitivities at a lower rate than that. And that's partly due to the fact that a lot of surgical site infections dealt with in primary care. They go along to see the GP, and the GP prescribes some antibiotics. And the vast majority of surgical site infections have been successfully treated before a culture result is back. We're doing a study at the moment where we're trying to improve the pickup of surgical site infections, and we've been asking GP colleagues whether they'd be happy to send a swab so that we can get a culture and sensitivity within this randomised control trial. and have met significant resistance, which kind of backs up that feeling.
Okay, thanks, Ewan. Now that Ewan has joined the call, any final questions for Ewan specifically, who was one of the senior authors in the paper and did a lot of the statistical analysis really?
Yeah, I think probably Ewan will want to talk about the finding that the checklist, when it's available in a hospital and it's not used, is associated with higher SSI than in hospitals where it's not available and is not used. I think one of the things that has been said is that it may reflect the institutional attitude to guidelines, and probably that reflects on SSI. Ewan, what do you have to say to that?
Yeah, it's a good question. So surgical site infection is associated with a lower rate of both mortality, of complications, including surgical site infection. And that presumably doesn't relate to the, well, who knows, but it presumably doesn't relate to the contents of the checklist itself, but reflects a broader safety culture, or just, it's just describing some variation in the facilities in which the patient's being treated, which isn't being captured by another variable. So we've got a specific, there's two checklist papers being done at the moment. There's one looking at emergency laparotomy, which is an abstract form and in a draft paper form at the moment. And the data on checklists from Global Surge 1, Global Surge 2, the GASOC study, which was the African Surgical Outcomes study, and the ISOS study, the International Study of Surgical Outcomes, is all being pooled by Ariadne's lab, the Ariadne labs in Boston, which is Atul Gawande's lab, on the, because this is the 10-year anniversary of the introduction of the surgical safety checklist, or certainly the publication of the New England Journal paper on it. So there's going to be some papers coming out using the same data. With regard to your specific question as to why are outcomes worse in institutions that are reporting that they have the surgical safety checklist available, but it hasn't been used for that patient, well, it may be to do with the circumstances under which that individual patient is being treated. So it could be related to the urgency with which they've been treated, so there hasn't been time to do a safety checklist. There isn't a clear correlation between emergency as patients being labelled emergency versus being labelled as urgent, but there is a relationship between the time in hospital from admission until knife to skin and surgical safety checklist use, and that is coming out in the paper which has been published at the moment. It may be that there's something else going on which isn't described, which is something to do with the implementation of the checklist. I mean, worldwide now, the checklist story is more, rather than checklist yes or no, it's about checklist successful implementation or not. And there was a prominent paper from Toronto 1 or 2 years ago where they introduced the checklist and showed absolutely no effect on either complication rates or mortality rates. And so there's been a lot of reflection on why that might be. So there's a few things relating to a safety culture within the institution itself, relating to the individual patient and the circumstances in which they're undergoing surgery, and potentially the actual implementation of the checklist and whether that has been successful or not.
Thanks very much indeed, Ewan. We'll move on to the next paper, and this paper is going to be presented to us by Hannah Burns, who is a core surgical trainee here in the west of Scotland. So once again, just for the next 10-15 minutes or so, if you wouldn't mind muting your mics to stop any feedback. And first of all, can you just confirm, can you all see that? PowerPoint, is that projecting to you all?
Yeah.
Yeah.
Hannah. So this paper is on laparoscopy in the management of appendicitis in high, middle and low income countries. The aim really was to decide whether surgical management of appendicitis will differ worldwide, and whether the complication rates differ depending on whether you're low, middle or high income country. And whether the laparoscopic approach is beneficial depending on your socioeconomic group. So it's reported that 17 million deaths resulted from surgical pathologies in 2010, which was reported as higher than the combined rate of death from causes such as HIV and AIDS, TB and malaria. That your access to safe and affordable and timely surgery is also dependent on your socioeconomic group, and that appendicitis is common worldwide. And it says in the Global Burden of Disease study that it had a higher prevalence of disease and disease burden depending on your socioeconomic group. The surgical approach varies. It also varies amongst different high Human Development Index countries and amongst Human Development Index countries as well. And it's been proven beneficial in high development index countries, and whether that is related to ones of low and middle high Human Development Index groups in terms of diagnostic laparoscopy and also therefore a reduction in complications and therefore the cost of that, versus in low income countries whether training, maintenance and financial aspects need to be taken into account. So 52 countries were recruited. They were recruited through the Global Surgery Network, through social media, through personal contacts. It was the same in terms of consecutive sampling over 2 weeks within a 6-month window, which was July to December of 2014. There was no minimum number of procedures needed to prevent bias against small centres, and each hospital could submit data for more than 1 2-week period. So data was collected by local investigators. It was checked by local leads to make sure there wasn't any gaps in terms of patients undergoing emergency abdominal surgery. And this was vetted centrally using national leads, which signed off these results. So the data collected included some patient variables, age, gender, ASA grade, service variables, whether the WHO surgical checklist was used, the experience level of the surgeon, the anaesthetist, the use of prophylactic antibiotics, and then compliance with evidence-based standards and the surgical approach. It was commented on whether the appendix was perforated or not perforated, what the overall complication rate was within 30 days. Surgical site or organ-space infections were defined by the Centre for Disease Control and Prevention. So results, so there were 4,546 patients, 52 countries, approximately 55% were from high Human Development Index countries, 34% from middle, and 11% from low Human Development Index countries. In terms of the results, in the low Human Development Index countries, the ASA of having kind of significant systemic disease, ASA 3 or more, was a lot higher. More procedures were done at night. Fewer were done by senior surgeons. An extremely small amount were done by laparoscopic approach, and there was a higher rate of perforated viscous. There was also noting that the patients tended to be male and younger age, that the use of the WHO surgical checklist is a lot lower, as well as was the use of prophylactic antibiotics. In terms of complication rates, when they were adjusted, they didn't show any differences depending on the socioeconomic group. However, it did show that surgical site infections were more common in low and middle human development index groups. And there was also no association with organ-specific infections depending on the socioeconomic group. And in terms of laparoscopy, it showed that there was fewer complications and surgical site infections amongst all groups. And then this was compared for low and middle human development index groups using kind of a like for like, which also showed a reduction in all kind of complications as well as surgical site infections. And it showed absolute risk reduction of overall complication rate of 6% with no perforation and 17% if there was a perforated viscus. So in terms of a summary of the findings, it showed that in low and middle income countries, laparoscopic approach for an appendicectomy is infrequent and that surgical site infections are much more common. That overall complication rates don't differ when they're adjusted, but a laparoscopic approach reduces overall complication rate and surgical site infections, regardless of what socioeconomic group you belong to. And then in terms of kind of strengths of the paper, so it's one of the first really of international data collection that incorporated low, comparing low to middle to high human development index groups. It shows that it can be done. And there was an easy method of data collection of standardized data to ensure that whoever can collect it worldwide. And then it demonstrated the global differences in the surgical approach to appendicectomy and the frequency of surgical site infections. In terms of weaknesses, I thought that only 11% of the cohort were from low human development index groups, and therefore whether they were kind of accurately represented and whether they were clustered amongst these countries to see kind of whether it is an accurate representation. The method of recruiting investigators could sideline the more rural areas in terms of whether they had access to social media and whether they kind of belong to this kind of partnership of global surgery. 30-day follow-up as the previous thing that Stuart discussed, that 30-day follow-up, it was difficult to maintain. And again, most of it was collected from date of discharge rather than after 30 days. And then in terms of the comparison for laparoscopic surgery versus open in low and middle socioeconomic groups, it was actually quite a small percentage of the overall patients, and therefore whether it kind of does hold significance. And then I just thought interesting points of discussion would be whether the benefits of laparoscopic surgery would outweigh the difficulties of cost, training and upkeep of the equipment, and whether it actually could be feasibly implemented long term in multi-centres. Whether surgical site infections, whether the rates of it could be reduced using other methods, like implementing new surgical techniques or a standardised approach. And then how can we standardise systems for measuring patient outcomes, including follow-up in low and middle high human development index groups? And then how can we include more centres to take part in data collection to ensure that the data isn't just a snapshot?
Thank you very much, Hannah. So if you want to participate, folks, then you'll need to turn your mics on. Maybe for fairness, we'll turn to Kings first. Your comments on this paper and questions about it.
while Kings is still thinking, I'll stop.
Yeah, Oxford started off.
So, appendicitis is a spectrum of disease where you get a little inflamed appendix and you get total peritonitis. And a lot of the times in the low-income countries, you get total peritonitis. So your laparoscopy has a selection bias, even in high-income countries. You didn't address that. So you can't assume that laparoscopy taught worldwide would be a better option because this is a spectrum of disease.
Well, sorry, I'm going to go you. Are you still on the line, Ewan? Okay.
Yeah, I'm still here. It's breaking up a bit, but yeah, I'm still here.
Okay, so the contention was that we can't conclude that laparoscopy is superior in terms of SSI reduction because of the problem of incomplete case mix adjustment and in particular disease severity. I think that was Kakila's point.
So we know in high-income countries that laparoscopic appendicectomy is associated with lower surgical site infections, and that's randomized data. There is no randomized data from low and middle-income countries. So the question is whether taking data from the high-income setting, which is now, the Cochrane review is pretty conclusive and has been for 10 years. The surgical site infection is lower in laparoscopic appendicectomy using randomized data compared with open appendicectomy. So the contention is, or could be, is that not going to be the case in a low and middle income setting? Now I take the point of the difference in presentation of disease. So if someone is presenting with 4-quadrant peritonitis, are they better served with an open procedure, which may be a laparotomy in a low and middle income country setting with a midline laparotomy, or an open right iliac fossa incision? Now, who knows? I, as a surgeon, don't think that you can do an adequate washout of 4-quadrant peritonitis from a right iliac fossa incision, and think you can do that better laparoscopically. So you could then say, does the argument come down to, are people better served with a midline laparotomy when resources are stretched, or if it's possible, can you do laparoscopy? But it is, of course, confounded, and it is tricky to know whether high-income country conclusions, to what extent they can be applied in low-income settings.
Just to answer that, I'm talking from experience from low-income country, that when you see peritonitis and you have access to be able to introduce the scope and do your 4-quadrant washout, is not feasible in the type of appendicectomies you see in the low-income countries, where the disease presentation, there's delay of presentation. Even if you had the technology of doing laparoscopy, you can't get the scope in because it would be too dangerous and you've been operating bowel because everything is so stuck. So I just feel that we're looking at different type of diseases here, and you can't conclude that laparoscopy is best. What you have to look at is the like for like. I don't know, Soji, do you want to come into this? Kings.
Yeah. Thanks. Actually, what you have said is valid. In terms of case mix, we see the patients a bit much later with peritonitis, but there are some that do come early, and those ones are amenable to laparoscopy. On the whole, I would believe that laparoscopy should be introduced. However, with a caveat that there should be patient selection, particularly at the beginning in this low and middle income country. So it will not be for a complicated case of full-blown peritonitis, but if you have some that present early with straightforward appendicitis, then those ones should definitely be offered laparoscopic appendectomy first.
I could add just a little taste of some of the results we got from Peds Surg Africa. We had 250 patients under 16 who had appendicectomy. So 57% that presented had a perforated appendix. Laparoscopic appendicectomy was highly significantly associated with lower risk of SSI.
How many had laparoscopy out of that 257?
So out of the 250 patients, almost a quarter had a midline laparotomy, 10% had laparoscopic appendicectomy, 65% had the traditional lambs or gridiron.
I think the point is that those ones that had laparoscopy, probably are the type that you also see in high-income countries, which goes on to buttress what Kokela is saying, really, that probably they are not perforated, and therefore it's not the same case mix. I think that's the point.
So this was adjusted, like global surgery was adjusted.
Okay.
I think we can't adjust for everything, but as much as you can in terms of perforation and duration, delayed presentation, and ASA score is what it was adjusted for. So there's a difference between localized perforation and full quadrant perforation.
Right.
But the other confounding factor with our study is it that the centers that have a sort of more advanced system for reducing surgical site infection
have
laparoscopy, and therefore they're getting lower SSI rates? It's very difficult to capture, although we did collect data on resource availability, and we do have some score for peds surgery capacity of the institutions.
Okay.
It's very difficult to capture that culture, isn't it? So I think that's one of the confounding factors that we can't adjust for in this paper either.
Perhaps Naomi could say a bit more, and it'd be interesting to see from the Global Search paper as well, to answer Kokela's question about problems potentially associated specifically with laparoscopy. Are there complications directly attributable to laparoscopy?
There were none in Peds Surg. I don't know about global surg.
No, we saw no complications associated with laparoscopy.
In terms of things like bowel perforation, which is the concern.
So a few comments. So I would agree completely with what Soji and Naomi have said. I disagree that perforation requires an open operation. Thinking from about 15 years ago, there's really high quality data to show that it's just simply not required. I would completely agree with Naomi with the difficulty in dealing with the confounding. As best we could, we did a propensity score matching of patients one-to-one within low and middle income countries, which doesn't get round selection within the hospital itself. So those with four-quadrant peritonitis being selected into open, and those with minimal symptoms being selected into laparoscopy. That confounding definitely persists, and a lot of the effect may be due to that. However, as best we can with these observational data, we have found the same as what has been demonstrated using randomized data within high-income settings, which is that even in complicated laparoscopy, even in complicated appendicitis, and there's been a couple of trials, randomized trials, randomizing only complicated appendicitis, so those that are perforated, that there are still better outcomes with laparoscopy compared with open.
I think the point you're making is that I'm looking at the children's population group, that yes, in the high-income countries, like for like, complex patients done laparoscopically will have a better outcome. But when you have the kids coming in a low-income country setting where you've got no space to put the scope in, and it's complex. They all get selected out. They have open operations because it's too risky to put a scope in. And I'm coaching countries kind of in the middle income setting where laparoscopy is used routine.
Yeah, I mean, I would agree. There are some cases that an open approach will be more appropriate. Absolutely. If it's not safe to perform laparoscopy, then an open approach should be performed. But the message, I think, from these data and from what Naomi is saying, that in appropriate settings, in appropriate patients, laparoscopy gives you at least the same outcome, but probably better outcomes. And you could broaden this discussion out to the benefits of trying to introduce advanced surgical skills into, into low and middle income country hospitals. That by having consultants, by having surgeons or clinical officers even who have these skills, improves a lot of other aspects of the delivery of surgical care. The diagnostic laparoscopy in our high-income institution is used a lot, particularly in young women with lower abdominal pain, which can be particularly useful if there's not easy access to CT scanning. So there are other benefits to the introduction of laparoscopy beyond the treatment simply of appendicitis, obviously.
Yes, I suppose that relates to one of the questions that Hannah posed in our discussion, was about benefits versus costs of the introduction of laparoscopic surgery in low and middle income country settings, and definitely I'm keen that we brought out that debate. But before we do, are there any other specific comments or queries about the paper itself? Anyone ask any questions?
How did you calculate reduction of complications?
Say your question again, sorry.
Reduction of complications, how did you calculate that?
I think it was all-cause complications used, wasn't it?
Sorry, I didn't quite hear the question, but the complication rates were looked at in a number of different ways, including looking at overall complication, looking at surgical site infection, first with multivariable, multi-level models, so models that are accounting for all the observed variables that we know about the patients, together with their clustering within hospitals, within countries, as a first stage. Then as a second stage, as a propensity match, the propensity score matched, where the characteristics of patients who went into laparoscopy are matched to the characteristics of patients who had an open procedure, to try as much as possible to deal with the confounding related to the observed variables. It doesn't tell you anything about the confounding relating to the unobserved variables like selection bias. And then, using a logistic regression analysis, producing an odds ratio of whatever the outcome is for that, for low versus middle versus high income groups.
Okay, so there was no way to see of any association with reduction of complication rate in each group?
Do you mean between high, middle and low income groups, whether it's possible to conclude about the relative prevalence of all complications?
Yes.
No, we could conclude that. It wasn't possible to make that conclusion. But obviously these all are observational data, and problems of non-observed variables not being accounted for are much more completely dealt with in a randomized trial environment. As we've said, this randomized data is not available in low-income settings, and so these observational data are interesting and hopefully based further prospects. So what are people's thoughts then more broadly about the role that laparoscopy might play in the development of surgical capacity in low-income countries? Is this an investment that is being driven by industry? Is it a development that we should be investing in?
I think the answer is out there already, because in a lot of, I don't know if you're aware that there's a charitable organization called Kids OR, and Storts is providing a lot of donations to have children's theatres put up in various parts of, mainly starting up in Africa, fully kitted out for endoscopy and laparoscopy. So laparoscopy makes a huge difference. I mean, we've seen that in cholecystectomies in the low-income countries. The reason why I made the point about appendicectomies is that because it's a spectrum of disease, and you need to select out which one will be suitable for laparoscopy or not. But overall, laparoscopy is something to invest in because I think the jury is out just looking at cholecystectomies being done in low-income countries.
Thanks, Rika.
I'm just thinking back to Nice. Nee did an excellent talk at PAPSA in Lagos. I think it was entitled something along the lines of, it's not a question of if laparoscopy should be introduced in Africa. It is, how can we make it safest and when? So it's going to come in anyway. That's not a question anymore. It's how best to support organisations to bring it in to have the best effect for patients and in the safest way, rather than people just having a go, not necessarily having the right equipment, not necessarily having the right training, and giving it a go. It's actually much safer to support institutions to bring in laparoscopy in the best and optimal way possible for patient outcomes.
One of the most, sorry, I
don't know if you want to comment.
No, I think you've summarised it nicely. I kind of alluded to the fact that we wouldn't expect people in low middle income countries today to suture with chronic catgut or those sorts of sutures, because we recognise that there are real surgical benefits to doing things in a particular way. So it is a question of introduction. Whether we like it or not, people are taking themselves off to get trained in different places, and it's trying to support a more cohesive training program, which makes sense for a safer, safer delivery.
One of the objections raised against investment in the development of laparoscopic surgery is that our focus should be perhaps much more be on widening access to the most basic of surgical services, rather than encouraging the use of more time-consuming methods of conducting surgery in small numbers of high-volume city centre settings.
I don't think the two are mutually exclusive, Stuart. I mean, of course, we should be doing both. And as Naomi says, the introduction of advanced surgical techniques across the board is, something which is and should happen. So the two need to happen in tandem. They're not mutually exclusive. And certainly there shouldn't be some belief that we should stop the introduction of some particular surgical approach in order to focus on another one. Sorry, I'm being attacked by a basset hound at the moment.
Thanks very much for providing a counterbalance to that, Ewan. Any final comments on that?
I've got one other comment actually on the last paper. Or if we're
Sure.
I just had a really interesting conversation with Emmanuel Macassa. I guess everyone knows who Emmanuel Macassa is. He used to, so he was the Zambian representative at the WHO, the Ministry of Health. But he's been the one that's really led the movement for global surgery and got the World Health Organization resolution passed to get surgery incorporated into emergency universal health coverage. So he was saying the importance of promoting global surgery within the global health agenda is to, one way of doing that is to latch on to areas that are currently high priority on the global health agenda. And so things like antibiotic resistance are very high priority at the World Health Organization. If you can sell the need for safe surgery in order to avoid antibiotic resistance and put those together as a package, it actually helps promote global surgery as a whole. And therefore we should be embracing things like this media storm, whether it's appropriate or not. It's a good way to promote global surgery and the need for safer surgery globally.
And that's actually true, because I think I've discussed this in the past at Global Search Forum. I'm aware that there are calls now from Bill and Melinda Gates Foundation that's currently on for geographic patterning of antimicrobial resistance around the world. And in the current calls, there is a call to India, another one to Africa, and I think another one to Europe or so. So I think things like that are things that we can easily latch on, like low-hanging fruits for global surgery to be able to make its impact known. So I think I agree with you.
Yeah, I would agree as well. I mean, I think I think we should be in surgery. I think we should be smart about what is going to appeal at the WHO and try and latch onto that. I mean, just because you mentioned it, as I'm sure you know, the Zambian surgical plan mentions specifically the expansion of laparoscopic services in Ndola and in Lusaka, with teaching units to be established there, and Alex in Ndola has already got a laparoscopic staff. So laparoscopy is something which is already built into the Zambian surgical plan.
Okay, thank you very much. An interesting final point. Naomi, I think we'll conclude the meeting at that. Thank you, Ewan, very much for joining us and providing expert commentary on these papers. Great to see colleagues elsewhere around the country for a really good, robust academic discussion, and I hope everyone does enjoy it. We don't have a date as yet for our next journal club, but we will be in touch with that. Anything to add, Kat?
No, only that it will be in Oxford. So we will, as you know, as GASOC, we'll have a chat about a good paper and what theme to go down.
Okay. Thank you all very much and enjoy the rest of your evenings.
Thank you very much.
Thank you.
Oh, thank you. You have not reminded us.